So the next class of diuretics, the drugs acting on site 2, they are also called as site 2 diuretics. As this site 2 is present in the ascending loop of Henle, so the diuretics which act on ascending loop of Henle, hence they are also called as loop diuretics. Next one, as we observe, out of all the site 1, site 2, site 3, site 4 diuretics, this site 2 diuretics is responsible for 2-chloride sodium, okay, sodium and potassium. So this sodium potassium 2-chloride sym-porter or co-transporter, it is present on ascending loop of Henle. So this site 2 diuretics is responsible to inhibit this co-transporter, and when they inhibit this co-transporter, there is no reabsorption of 2 chloride ions and 1 sodium ion, 1 potassium. So total 4 ions they will retain into the urine and they are excreted through the urine. Okay. Hence, this site 2 diuretics they are responsible to excrete 2 chlorides, 1 sodium, 1 potassium. It is much more than any other site diuretics. So they are also called as high ceiling diuretics. They are having the higher activity or highest activity as compared to the other diuretics. Hence, they are called as high ceiling diuretics. Okay, so these two diuretics they are responsible to inhibit the sodium potassium 2 chloride co-transporter in the ascending loop of Henle. Hence, it is often called as high ceiling diuretics as it is more effective than any other diuretics. It decreases the reabsorption of single sodium, single potassium, and 2 chloride ions from the tubules. So you can see here these how the mechanism of action of loop diuretics are present. Okay, so this is 2 chloride potassium chloride ions, that is the co-transporter, and this co-transporter is inhibited by these loop diuretics such as furosemide, and due to inhibition of these co-transporter, the reabsorption of these ions inhibited, hence more amount of ions they are excreted through the urine, hence they are the high ceiling diuretics. These high ceiling diuretics, loop 2 diuretics, they are classified to two types. One depending upon their structure. One is sulfamyl anthonylic acid like diuretics. Second one, phenoxyacetic acid diuretics. So depending upon the structures which they are present, they are classified to these two types. Drug furosemide, azosamide, bupetanide, they comes under the sulfamide anthonic acid like diuretics, and drug ethacranic acid is the example of phenoxyacetic acid diuretics. Okay, so this is the structure of furosemide. They are comes under the class that is the 5-sulfamyl anthonylic acid. So 1, this is 2, this is 3, this is 4, and this sulfamyl is present at the 5th position, so it is called as 5-sulfamyl, and this is benzene ring along with the NH2 and COH, it is called as anthonylic acid. So it is called as 5-sulfamyl anthonylic acid. And if you just observe the structure of furosemide, it consists of this part, that is the anthonylic acid like derivatives, as well as the sulfamyl part is also there. So these are the derivatives of 5-sulfamyl anthonylic acid. So furosemide is an example of high ceiling diuretics, and it is the derivative of anthonylic acid or orthoaminobenzoic acid. Now, same 5 alpha, 5 sulfamyl anthracyclic acid is present. So at the first position COH is present, and at the second position amine group or substituted amine is present. Here in the second structure there is no amine group or substituted amine group at second position, but at the third position there is a presence of amine group. So these drugs, they are also called as, these are called as 5-sulfamyl anthracyclic acid derivatives, and these are called as 5-sulfamyl 3-amino. So amine group is present at this position, so 3-amino benzoic acid derivative. So that is the difference between these two. So the some drugs they having this type of structure, and in some drugs they having this type of structure. Both are responsible to give better activity. Now next part, that is the structural activity relation, that is the SAR for this side 2 diuretics, generally the 5-sulfamyl 2 or 3-amino benzoic acid derivatives. In some structure the amine group is present at the second position, in some structure the amine group is present at the third position. So the first point in the SAR is that at the first position there must be presence of COH group, that is the carboxylic acid. This carboxylic acid, if it is present at the first position, they are responsible for optimum diuretic activity. If we have removing this COH group, it will decreases the activity. But sometimes other groups such as tetrazole, it may be also shows respectable diuretic activity, so that they can show some kind of diuretic activity. But if we are replacing COH with any alkyl group or any other group, it will decrease the activity, or it will diminishes the activity. Next part, at the fifth position there is a presence of sulfamyl moiety. So this sulfamyl moiety is necessary for the activity. Next part in that, this sulfamyl, it must be unsubstituted. So the NH2 which is present in sulfamyl, that is this NH2 part, this part must be NH2. There should be no any substitutions like NHCH3 or NCH3CH3. Such substitutions should not be there to show the maximum activity. Then the third part is that at the fourth position, that is here X is given, at the fourth position there must be presence of a group such as halogens or trifluoromethane, phenoxy, alkoxy, anilino, benzyl group. Such groups can be present at the fourth position, which can give the optimum activity. Now the important part between these two structures is that the presence of amine group. In one structure it is present at the second position here, and in second one it is present at the third position. So when there is a changes of the position of amine group, it will retain the optimum or maximum activity. So substitution that present on this position, it can be tolerated at 2 amino group of 5-sulfamyl is extremely limited. So here there are only few substitutions which can be substituted instead of these are. So which are the substitutions? Furfural, benzyl and thionyl methyl. Any other substitution cannot be substituted in the second position amine group. Okay, but in the position of third amino group, where amine group is present at the third position, we can use variety of substitutions without affecting the optimum diuretic activity. So that is the difference between these two. Only the furfural, benzyl and thionyl methyl, it can be substituted when the amine group is present at the second position. But when it is present at the third position, we can use wide variety of substitutions. As we have told that the substitutions which can be present on two amino group, they are limited in number. So only furfuryl, benzyl and thionyl methyl derivatives can be present. Okay. So depending upon this one, there are two substitutions which are present, that is the furfuryl substitution which is present in the furosemide and the azosemide. As we have told that at first position acidic group is must, but it can be replaced by tetrazole ring. So in azosemide this acidic group at the first position, it is replaced with the tetrazole ring. Okay. Another examples, basic on 3 amino benzoic acid, that is the substitution which are present at the third position. So this is one of the substitution. Alkyl substitution are present. Here the nitrogen, it is present in the form of cyclic structure. So it is bumetanide. This is one of the example. This is pyritanide. So it is not there for our syllabus, but this structure is there for our. So the next class of the side 2 diuretic, that is the phenoxyacetic acid derivatives, that is ethacrynic acid. Okay, the example is the ethacrynic acid. So this is the structure 2,3 dichloro. So 2, 3 dichloro, 1 oxobutyl phenoxyacetic acid. So this is phenoxy group, CH2COH is the acetic acid. So this is called as phenoxyacetic acid. In the last part of diuretics, that is the osmotic diuretics. So as the name indicates, these osmotic diuretics based on the principle of osmosis. So they increase the density of filtrate, and if density of filtrate increases, they prevents reabsorption of water. So the water remains in the urine, it will not undergo reabsorption into the blood. Similarly, they can increase the sodium and chloride excretion instead of their reabsorption. So there are some features of these osmotic diuretics. First one, passively filter. Second one, it limited reabsorption. They are inert and pharmacologically and metabolically, and they have high degree of water solubility. So they produces the osmotic pressure, they increases the density in the urine, hence their reabsorption of water and different ions, it is impossible or it is difficult for them to undergo reabsorption process. So they inhibit the reabsorption of water and sodium. They are inert and they are given intravenously. They increases the osmolarity of blood and renal filtrate. These are some points regarding osmotic diuretics. They also produces the effect on convoluted tubules and the descending loop of Henle, where actually the permeation for water is there. So they inhibit this permeation. So the water remain as it is into the urine, and it will not undergo reabsorption process. As the result, the volume of urine increases. So mannitol, it is one of the example. This is the structure. It is a prototype for osmotic diuretics. It is D-mannitol. Another example, isosorbide. This is the another example which comes under the osmotic diuretics. Okay, we are starting with a new chapter called as anti-anginal agents. Okay, so the anti-anginal agents or the anti-anginal drugs, these are the drugs useful in the treatment of angina pectoris. So angina pectoris is the condition where there is an insufficient supply of blood, that is the oxygen, to the heart. That is the ischemia takes place. Hence, there is no or efficient supply, less efficient supply of the oxygen or blood to the heart. So due to this, the pain in the heart creates and it results into the ischemia. So why there is insufficient supply of blood takes place? So the main reason is that the coronary atherosclerosis, it is the main responsible to cause the cardiac ischemia. Okay, so generally this is artery, this is the internal part of the artery, you can say lumen of vessels. Okay, so when there is no any cholesterol deposition or atherosclerosis in the artery, then the blood can flow normally through that artery and they can supply efficient amount of blood, that is the oxygen, to the heart. Okay, but what happens due to the atherosclerosis? Now you can see here the plaque formation of the cholesterol crystals are deposited inside the wall of artery. So when inside the wall of artery the cholesterol crystals deposition takes place, then the diameter of the artery decreases, and when the diameter of artery decreases, less amount of blood can flow through the artery, and it results into the forcefully flow of blood through the artery, and it causes the increase in the blood pressure. It increases the workload on the heart. Sometimes what happens, the remaining space, there is a blood clotting takes place, and due to that there may be chances of complete blocking of this artery, so there is no blood supply to the heart, and it results into the cardiac ischemia, or you can say heart attack. It is one of the reason there is insufficient supply of blood to the heart. Okay, so that is the some basic information regarding angina pectoris, why it takes place. Okay, so the oxygen demand to the heart and oxygen supply to the heart, if it is equal or it is managed, that is the oxygen demand of heart, there is no problem. But what happens if due to the any condition, if oxygen demand is not completed by giving the sufficient amount of oxygen, or there is no sufficient amount of oxygen supply to the heart, this results into the ischemia. Okay, so there must be the sufficient supply of oxygen, or the what is the demand of heart. According to that, if supply of oxygen takes place, this maintains the proper health condition of the heart. If you are doing the exercise, then your heartbeat increases. Why it is increases? Because during this exercise you require more amount of oxygen to the heart. So the more amount of oxygen is supplied to the heart, more amount of blood is circulated. By pumping, there is more amount of inflow and outflow of the blood. Oxygen takes place. That's why it is necessary for the heart to maintain the oxygen demand and oxygen supply. So ischemia is generally called as angina pectoris. That is the imbalance between oxygen demand and what is the supply of the oxygen. If the oxygen demand is not satisfied through the oxygen supply, it will result into the ischemia. So these angina pectoris, they are classified into exertional angina. So it is again classified into stable, initial, or accelerated angina. Then second one spontaneous. Third one mixed angina. Okay, exertional angina means if you have any problem with the heart and if you are doing the exercise or any work, and at that time if there is a ischemia takes place or any insufficient supply of blood takes place, it results into the exertional angina. If spontaneous angina means you are not doing any work, you are stable, then also if the ischemia takes place, angina takes place, it is called as the spontaneous. And mixed angina, it is the unstable angina. So exertional मध्ये stable angina येतं, mixed मध्ये unstable angina. So how the oxygen demand is determined? Okay, so this is oxygen demand is depending upon its contractility, heart rate, tension, preload, afterload, or is determines the oxygen demand of the heart. Now, we are going to the next part, that is the anti-anginal drugs. So, anti-anginal drugs, they are classified generally into these five types. First one is the nitrate derivatives. In that, short-acting nitrate derivatives, long-acting nitrate derivatives, then beta blockers, then calcium channel blockers, then potassium channel opener, and there are some miscellaneous agents or other agents which are act as anti-anginal agents. First, we will start with the nitrates. Okay. So what is the action or pharmacological action of the nitrate? Generally, this is the structure of nitrate. All the nitrate, they consist of this nitrate type of structures. So what is the pharmacological action of these anti-angiogenic drugs? That is, they are responsible to dilate the vessels. So when the vessels are dilated, the workload on the heart decreases, the load on the heart reduces, and the wall tension decreases. It also redistributes the coronary circulation, which causes the dilating the artery. It causes collateral circulation and it reduces the wall tension. And this reduction in wall tension is responsible to to flow of blood through the right ischemic areas. Okay, so these are the functions what these drugs for. What is the actual mechanism of action? So when we are giving the nitrates as a drug, these nitrates, they are converted into nitric oxide. Nitrates, they are converted into nitric oxide. This nitric oxide, this nitric oxide is responsible to activate the guanyl enzyme guanyl cyclase. This guanyl cyclase is responsible for the conversion of GTP into cyclic GMP. Likewise, adenyl cyclase is responsible to convert ATP into the cyclic AMP. Similarly, this guanyl cyclase is responsible to convert GTP into cyclic GMP. And this activation of this enzyme is done by the nitric oxide. This cyclic GMP, along with the myosin light chain kinase phosphate, together they are responsible for the relaxation. So what is the function of cyclic GMP is to convert myosin light chain kinase phosphate into the myosin light chain. So it causes the dephosphorylation. So generally cyclic GMP is responsible to activate the enzyme protein kinase, and this kinase enzyme is responsible for the phosphorylation or dephosphorylation. So generally this kinase enzyme is dephosphorylate this myosin light chain kinase phosphate into the myosin light chain, and this myosin light chain is responsible for the relaxation of the vessels. Okay, if cyclic GMP is not there, then myosin light chain kinase phosphate is formed. It is along with the acting, it causes the contraction. So when we are giving the nitric oxide, this nitric oxide first activates the guanyl cyclase. So this activated guanyl cyclase converts GTP into the cyclic GMP, and this cyclic GMP activates the enzyme kinase, and this kinase causes the dephosphorylation of myosin light chain kinase phosphate into the myosin light chain. So the phosphate group removal takes place, that is the dephosphorylation takes place, and this myosin light chain is responsible for the relaxation of vessels. If this kinase enzyme is not available, then myosin light chain kinase phosphate is formed, so it causes the contraction. So activation of the cyclic GMP through nitric oxide of the drugs, they are responsible for the dephosphorylation of myosin light chain kinase phosphate into the myosin light chain, which is responsible for the relaxation. So the blood vessel relax, blood vessels जर relax झाले तर diameter त्यांचा वाढतो, diameter वाढला, more amount of blood can be flow through the vessels and more amount of oxygen and blood can be supplied to the heart. Now suppose this is the vessels, there is a deposition takes place. Okay, so less amount of blood can flow this through this less amount of blood can be flow. But when nitric oxide causes the vasodilation, what happens? the diameter increases. So this distance between these two wall increases. And due to that increase in internal diameter, what happens? If there is atherosclerosis also, due to the increase the distance, more amount of blood can be flowed through the vessels. And when more amount of blood can flow through the vessels, more amount of blood can be supplied to the heart. That is, the more amount of oxygen supply takes place to the heart. So that is the mechanism of action of nitrate and its derivatives. Okay, so this is given in the format again, nitric oxide. This nitric oxide, it activates guanyl cyclase. Guanyl cyclase activates conversion of GTP into cyclic GMP, which activates the enzyme protein kinase, which causes the dephosphorylation. And this myosin light chain is responsible for the relaxation of blood vessels. The nitrate derivatives are used for all kinds of angina pectoris. In heart failure also they can be used. These are the examples: glyceryl trinitrate or nitroglycerin, amyl nitrate, isobamine nitrate, erythryl tetranitrate, pentaerythrol tetranitrate. So these are the useful anti-anginal drugs which releases nitric oxide, which causes the vasodilation. So which are short acting? So these three are short acting, and these are the long acting nitrate derivatives.